I got a couple extra remarks today. Yeah. Oh, sure. You okay with it? Yeah.
Hi everyone, thanks for joining. We're going to get started now. Today we have approximately 45 minutes, and just as a reminder, one question, one follow-up. We have Dr. Brown, Dr. Yaffe, and Mr. Anderson here today, so I'll turn things over to Dr. Brown to get started.
Great, thank you. And before we start reviewing numbers and charts today, I want to talk bluntly with you about two critical issues that underpin all of the data I will share. The first is the spread of COVID-19. We are at a dangerous point. The number of cases in Ontario is growing between 3% and 5% almost every day. There are already more than 400 COVID-19 patients in our intensive care units, and mortality in our long-term care homes is now on a pace to exceed the tragedy of the first wave. But as importantly, COVID-19 is now in every region of Ontario. This is no longer a problem of a small group of cities or one region of the province. More than half of our intensive care units in Ontario are full or have only 1 or 2 beds left. 40% of our long-term care homes are at outbreak. The pandemic will have serious consequences for our health in every region of Ontario. I know that the people working in our hospitals will do everything to help cope with this crisis. Hallways will be used to house makeshift intensive care beds. Field hospitals will hold patients throughout the winter. But as we climb closer to 1,000 intensive care beds, about half of our capacity, filled with COVID-19 patients in February, we will have to confront choices that no doctor ever wants to make and no family ever wants to hear. They will be choices about who will get the care they need and who will not. There will be choices about who receives oxygen or is transported to hospital. Decisions we are already seeing being forced on ambulance crews in California, where the virus has spread widely. And I want to emphasize that the choices will affect all patients needing intensive care, whether it's patients who have a heart attack, who've been in a motor vehicle accident, who have COVID-19, or any other cause. This also means care for thousands of patients waiting for surgery will be delayed or canceled while we add more patients to these wait lists. It is critical to remember that when care is delayed, patients get sicker and their prognosis worsens. Simply put, delays kill. At the same time, the impact in our long-term care homes is as or more devastating. We already have well over 1,000 deaths in long-term care in this second wave. We also have to acknowledge the anguish and the heartache of our most vulnerable senior citizens as they are cut off from their loved ones, as long-term care homes struggle to keep the virus out. As you'll see from the maps I will show today, long-term care homes across the province are now affected by COVID-19 outbreaks. And as the virus spreads, so will the outbreaks, and so will the deaths. And I want to be clear, the impact on our health system is already greater today than we have ever seen in Ontario's history. If we look at just one community as an example, Scarborough has already had many times more emergency department visits and hospital admissions than in an entire bad flu season. We are now only a few months into the second wave. And as my colleagues have shown, using Ontario data, the impact of COVID-19 is far greater than diseases like flu or anything else that it's regularly compared to. And stakes have just been raised. We'll discuss today in the briefing a new variant of COVID called B117 that has likely arrived from the United Kingdom. This variant is in the province right now. Today, the number of Ontarians with COVID doubles every 35 to 40 days, roughly every month to month and a half. But this new variant, if it spreads, will mean that the doubling time for cases could drop as low as 10 days. Now, the vaccine and this new variant is not more lethal, but because it spreads so much more quickly, if it gets out into the community, there is no question that we'll have more cases and many more deaths. People will die from the virus itself and from an overloaded health system that is unable to respond to their needs. The second key issue for today is controlling the spread of COVID-19. As you will see in the upcoming slides, the majority of Ontarians are working to follow the public health restrictions. Thank you. Your actions protect yourself, but they also protect other Ontarians. I know this can be hard work, and I know this involves hard choices about seeing loved ones and friends. But our actions are key to controlling the spread of the disease. However, there remains a substantial number of Ontarians who are not following restrictions, and their actions will undo the hard work and effort of those Ontarians who do. If we do not follow these restrictions, COVID-19 will continue to aggressively spread before vaccines have the chance to protect us, and this will have tragic consequences for us, for our health, for our province, and for our health system. The vaccine will come, and it will be in people's arms before many of us really even understand how quickly it's moving. But that is still months away. We have a big job to do right now. Any restrictions will take time to have an impact, but stopping the growth of the pandemic is not impossible. Other countries have witnessed the same growth that we have, and they've taken action by enacting and enforcing higher levels of restrictions. And it has worked. The Australians celebrated New Year's Eve, and their shops are open. The French have cut their cases by half. Germany is flattening its curve. But we must also support Ontarians who, by virtue of nothing more than the work they do and the communities they live in, face much greater risk of exposure to the virus. This means greater and more accessible testing, close engagement with community leaders, and support for people who do the essential work we all rely on every day, so that nobody has to choose between getting a test and putting food on the table. This means making workplaces as safe as possible. It means support for isolation when someone tests positive. It means income support, and it means protection from eviction. As I move into the numbers in today's briefing, I want to say a special thanks as well to Dr. Adalsteinn and her team, who have been instrumental in producing today's and many preceding briefings. And with that, I'm sorry, but the sign language translation will disappear as we go into the slides, and it will be back as soon as we're finished presenting the slides. So key findings, as we do every day or every time that we make these briefings, I want to just call attention to a few key issues. Growth in cases has accelerated and is now over 7% on our worst days. Almost 40% of long-term care homes have active COVID-19 outbreaks. Since January 1st, 198 long-term care residents and 2 long-term care staff have died of COVID-19. And our current forecast suggests that the deaths in Wave 2 in long-term care will outstrip those in Wave 1. COVID-19 ICU occupancy is now over 400 beds. Surgeries are being canceled, and the access to care deficit will continue with real consequences for health. Much of this is due to the fact that mobility and contacts between people have not decreased with the current restrictions. Survey data do show that the majority of Ontarians are helping limit the spread by following current restrictions. However, case numbers will not decline until more of the population follows their example. A new variant of SARS-CoV-2 called B117 could drive much higher case counts, ICU occupancy, and mortality if community transmission occurs. The doubling time for cases could drop by more than 2/3. And just to make it clear, this variant is in Ontario. This is not a hypothetical. The variant is here. It's just depending now on how fast it spreads. And without significant reductions in contact, the health system will be overwhelmed and mortality will exceed the first wave totals before a vaccine has time to take effect. I'll move now to a chart that we show or start each one of these update briefings with, and this is the total new cases per 100,000 residents per week across public health units. I think it's pretty easy to see the dramatic recent growth as the slopes of those lines curve up quite strongly. I think it's important to note that all the public health units are now above restrict, and the majority are above the control line. So this is quite substantial growth. Moving on and looking at COVID-19 testing percent positivity across public health units. Again, you can see the dramatic growth in a number of public health units there, and all are above that control level now in the province. There is not a single public health unit, or any of the results that we present here that are below that threshold. I think it's important to note that this is occurring despite strong testing volumes. So this is not an artifact of lower or reduced testing. This is persisting despite very strong testing volumes. I'll move on now to percent of COVID-19 test results returned within 2 days across public health units. We often talk a lot about the variation across public health units. You can see this variation persisting with rates going from about the low 60s to just into the high 90s%. Fast turnaround of test results is critical to both helping people isolate at home so that they don't spread the disease, allowing people who are negative to actually go about their work, and as importantly, initiating case and contact tracing and helping control the spread. This is a number that's critical to fight against the disease, and one that needs to move upwards. Moving on now, I just want to talk about the percent positivity by age group. We've truncated the chart a little bit here. We only go back to August now to give a little better resolution on the data. Again, the darker the square, and each square represents an age group, starting with the youngest age groups at the bottom, moving to the oldest age groups at the top. Each square represents one of those age groups. Right at the top, you can see the 75-plus group, the most vulnerable to COVID-19 infection, and you can see how that is darkened progressively over time. It's important to note, though, that all of these squares are darkening over time, and every square is over 5%, despite strong testing volumes. So cases continue to rise, percent positivity continues to rise, testing is stable. This means that the growth of the pandemic is particularly acute right now, and at that point that is, I think, no longer we can describe as precarious, it is dangerous. Let me move now to spend some time focusing on long-term care. You can see the curve here of deaths and cases. I think it's really important to call attention to that green curve, which is the cumulative deaths. This curve continues to become more and more steep. And as that curve becomes more steep, the number of deaths per day increases, or the number of deaths per week increases. And now, just thinking since January 1st, we've had 198 resident deaths and 2 staff deaths. Really important to note that this curve has increased virtually every time that we've given this briefing, and given the growth in cases, it will likely increase regardless of what we do, at least for a little while. I'd like to move now to some projections of mortality in long-term care homes. If you think that we had about 1,800 deaths in the first wave, we are now over 1,100 deaths, and under at least the worst case scenario, we would be looking at over 2,600 deaths by Valentine's Day, which is a significantly higher number than the first wave. That blue area behind the red bars are the actual deaths. That blue bar is the range of our estimation. You can see that now it's not going to be anything lower than 1,100, and there's a very good likelihood, given that slope, that we will start to approach that worst case scenario with a substantially higher death count in wave 2 than in wave 1. I'd like to now move and start to show some maps of the progress of the disease across the province. Starting here on July 1st, you can see the map there. Every dot is a long-term care home in outbreak, and the size of that dot reflects the number of staff and residents who are infected in each outbreak. That gives you a picture of where we were at the start of the summer. Here we are at the beginning of October 1st, 2020. You can see that the number, let me just go back to July here, the number of dots has increased, and the size of those dots has increased as we go along here. And I'd like to take you now to really kind of today, or close to today. This is January 7th. You can see now that every region in the province has homes and outbreaks. You can see that the number of those outbreaks has increased, and you can see that the size of these outbreaks is substantial. So important to note that this is now spreading across all the province, and as we noted in kind of my introductory remarks, as this spreads, so will cases and so will deaths. Moving now to mobility. I'll first talk about mobility around retail. This is what we're using sort of cell phone and other types of data. We're able to understand where people are in terms of the types of places they're at. You can see that there was a very dramatic spike in retail before the Christmas holidays. This came down, people visiting retail areas. You can see, if you look very closely, that there are some gaps or drops in visits to retail that happen just after the lockdown measures are put in place, but not significant drops. And I think more importantly, it's really important to look at sort of an overall measure of mobility. The panel on the left-hand side of this chart is the changes in people's visits to workplaces. The panel on the right-hand side is changes in people staying at home. And you can see here across a number of public health units, really there is no change up until the actual Christmas holidays. And then it returns right back up to, at least as far as we can see from the existing data, right back up to the previous levels. So we're not seeing any real change in people staying at home. And I think it's important to note that this line is really flat since July, which means that we really haven't seen a break in mobility since probably the nadir or the lowest point of the pandemic, despite growing case numbers. I want to move to some survey data that has been commissioned by the Fields Institute here and start to talk about people's behaviors. Great. So with current restrictions, almost 2/3 of the population are acting in a way that will decrease COVID-19 spread. And so, for instance, the top bar asks the question, are people in your neighborhood physically distancing? And about 25% say all the time. About 40% say most of the time, or at least trying. But there are 35% who report that people in their neighborhood are occasionally or never physically distancing. And that's a key step in actually breaking the transmission of the disease. Looking a little more into what will have been happening around the holidays here. In the last 4 weeks, how many people outside your household visited your house for a meal or a celebration or a stayover? About 32% of the population reported that 3 or more people visited the house. And for those who reported people visiting the house, 1/3 did not observe restrictions such as mask wearing or physical distancing, which is key to actually preventing the transmission of the disease, particularly if this is indoors. So about 2/3 of the population are working to try to break the spread of the disease, but I think their efforts will go and be undone if the entire province does not pitch in here. Now, let me go on to projections here. As before, what we do is we project based on the existing or current growth in cases where we think it's going to go. You can see there that really with case growth between 3 and 5%, that's the second and third line from the top, we're really pretty much exactly where France and the UK and the Netherlands are at the same point in their pandemic growth. And so we're facing the type of growth now that those jurisdictions have felt the need to take decisive action on to restrict. I won't get into the overall case numbers, save to say that if we do hit the 5% level of growth, which is quite possible, we'll be looking at over 20,000 cases a day by the middle of February. And if we get into a darker situation with 7% growth, where actually we have seen some days at 7% growth, we'll be looking at over 40,000 cases per day. This, of course, unfortunately translates into dramatic reductions in intensive care use. Dramatic reductions in intensive care unit capacity. And so we're already over 400 beds. And by the end of the first week of February, even under a very optimistic scenario of 1% growth, we will have over 700 beds filled. If we're at a more reasonable range between 3% and 5%, we'll be looking at 1,000 to 1,500 intensive care unit beds occupied by COVID-19 patients. And obviously at that point, it's no longer a possible level of capacity to support because we are expending the majority of our capacity in intensive care taking care of COVID-19 patients. We haven't shown a 9% growth rate, which is what is threatened by some of the growth that we've seen in other jurisdictions. But if we did, the number would be an almost impossible 2,000 intensive care unit beds occupied by February 5th. Continuing on here, I want to show the slide on intensive care unit admissions and hospitalization rates overall. For the last several briefings, we've been reporting a roughly consistent growth in this number each time. You can see now that over the past 4 weeks, there has been a 72% increase in hospitalizations and a 61% increase in intensive care unit patients. Given the growth in cases, given the increase in percent positivity among our older age groups, this trend will continue for a while. I'd like to now talk about the distribution of these intensive care unit beds across the province. It's important to note that we now have about a quarter of our hospitals with no ICU beds free, and another quarter have only 1 or 2 beds free. I think it's important to kind of present this because we're now looking at a situation where half of our intensive care units do not have the capacity to respond to emergencies, medical emergencies, whether it be for individuals like a heart attack or emergencies that might affect multiple people, such as violence or motor vehicle accidents. I also want to note that these hospitals facing crisis now are distributed across broad parts of the province. And perhaps as well also note that the hospitals that are most affected are also referral centers for the entire province. So this type of ICU occupancy compromises care across the province. This is no longer an issue of 1 or 2 regions, and it's no longer an issue of moving patients around to try to accommodate access to care problems. I want to note here the continuing access to care deficit. You will see a sharp blip up in the volume of surgery done over the Christmas holidays. This is a blip up, not in terms of absolute numbers in a way that would give us any comfort. This is compared to the volume of surgery over last year's Christmas holidays, which is typically a slow period. But you can see with the close of the holidays, that surgery has actually started to decline substantially again below 2019 levels. And just to kind of put this again into perspective for people, when we start to delay care, much of what we talk about in terms of tumor doubling time is measured in weeks. Cancers get larger, prognosis gets worse, and patients will die. Heart disease will worsen, and patients will die as they're unable to get access to care. But perhaps as importantly, there is large swaths of our healthcare system that are similarly compromised, everything from mental health care through to addictions care, through to care for chronic diseases. All these become compromised, and this builds up not only an access to care deficit, but a substantial health deficit that will persist and will be as inequitable or more inequitable than the rest of the pandemic. Of course, this translates not only to problems in access to care, it translates in problems in mortality. Daily mortality is increasing, doubling if the trends persist, to between 50 and 100 deaths per day between now and the end of February. To give you an idea of this in relationship to other causes of mortality, this would really put COVID-19 into competition for being the single greatest cause of mortality on a daily basis at that point, potentially larger than cancer and heart disease. It's already larger than virtually every other cause that we look at, but this will put it into the first position with very little opportunity for challenge. Now I'd like to talk about the new variant of COVID-19, the new variant of SARS-CoV-2, B117. And this is the variant that appears to be much more easily transmitted. We look at it as probably being about 56% more transmissible, but we're pretty confident that this increase in transmissibility, the ability for it to move around and infect other people, is at least 50% and maybe as high as 75% more transmissible. Fortunately, there's no increase in disease severity, and the vaccines are likely still effective. But the critical issue here is as case numbers grow, as that transmissibility leads to higher case numbers, it does lead to more hospitalizations, it does lead to more intensive care unit occupancy, and it does lead to more death. It's not an issue of changing the rate, it's really an issue of changing the overall number. Let me now talk about what this does to our modeling projections in terms of numbers of cases. Just advance the slide there, thank you. If the SARS-CoV-2 variant B117 spreads in the community, the doubling time for cases could drop to 10 days in March. Now, what you see here in the blue dots is a series of scenarios that we're running around the current variant of SARS-CoV-2, how its transmissibility leads to growth in cases. And you can see superimposed on that a black line. The black line represents what our models are predicting. And the blue dots represent all the different ways we've tried to run this scenario. As you can see right now, our models are functioning fairly effectively and doing a good job of predicting what the growth is. However, the red lines indicate the growth in new cases that would result from the new variant, B117. And you can see that if we've had one case introduced into Ontario in mid-October, even if there's a chance that 2/3 of any of these new cases introduced don't get transmitted at all, you can see that explosive growth in the red dots as the total number of cases take off, and the disease starts to get to almost near vertical growth in cases. The red dots obviously start to go vertical. The gray dots are the total number of cases, but you can see just how quickly that new variant dominates the transmission and leads to a much, much higher level of cases and a much, much faster rate of transmission. One of the questions we get asked often is what are the key components of what other jurisdictions have done to try to curb this spread. You can see here, as we looked at, say, Victoria, France, the United Kingdom, Germany, or Netherlands. It's important to know as well that United Kingdom, Germany, and Netherlands all have these lockdowns in progress right now. Stay-at-home orders, restrictions on movement, as we really saw in the first wave here in Ontario, are a common element to all of them. You can see a number of elements about really kind of closing non-essential activities, really strong attention to workplaces as well across all of these, and the importance as well of enforcement of this. Now, it's, I think, important to emphasize the value of enforcement and making sure that people understand what's going on and the importance of adhering to the public health restrictions. It's equally important to note, though, that it must be enforcement and support. So that people don't have to make choices that no one should have to make about actually protecting theirs and others' health. Returning now again to the key findings, growth in cases has accelerated. It can no longer be described as precarious given the persistence of a R above 1. It's over 7% on the worst days, which is getting into our worst case scenario territory strongly. Almost 40% of long-term care homes, or really 40% of long-term care homes, have active COVID-19 outbreaks. And since January 1st, almost 200 residents and 2 staff have died. Our forecast suggests that this rate of death will just continue to accelerate, and the cumulative death count is on track right now to outstrip that in the first wave. ICU occupancy is now over 400 beds, and our scenarios are predicting that this could easily double by the end of the first week in February. Mobility and contacts are not declining as we would hope in order to break the transmission of the disease or the spread of the disease, Mobility levels are really staying very similar to what they were in July, which means that the current restrictions will need to be augmented if the goal is to reduce case spread, reduce the crisis within our health system, and save lives. The new variant could drive substantially higher case counts. This will require hard work in case and contact tracing. It will require public health capacity to be able to control the spread of this new variant, and the ability as well to identify this new variant regularly using sequencing. And without significant reductions in contacts, the health system will be overwhelmed, and the mortality will exceed the first wave totals before a vaccine has time to take effect. I'll just conclude by noting the members here of the science and modeling tables who have contributed to this presentation and all the preceding briefings. And I'm very proud that they've been able to do this, really freely giving of their time as volunteers as they've gone through on this. That concludes the briefing. I'm going to turn it over now to Mr. Anderson to touch on some of the issues related to our health system. Thank you.
Thank you, Dr. Brown. Good morning, everyone. I'll be brief. I know we'll want to get to questions and answers. I just wanted to really highlight and echo one of the many points that Dr. Brown has made today that is critical for us. And that is that when we're talking about the impact of COVID, we're not only talking about COVID. We heard Dr. Brown talk about the very serious impact that has on their healthcare. So really what we're talking about is that when we stay home, when we follow the public health measures, we're doing that not only to slow the progress of this disease, but we're doing it for all of those people who have those other illnesses, the non-COVID illnesses like cancer and heart disease, and we're doing it for them. It is imperative that we find a way to flatten this curve and not have the kinds of numbers that Dr. Brown has just presented as early February. Thank you for your time, and I look forward to your questions.
We'll go to the phone lines. Just a reminder, one question, one follow-up. Over to the first question, please.
From Antonella Artuso at the Toronto Sun. Please go ahead.
Thank you. Doctors, in a race between the variants and the vaccine rollout, why would you be so concerned that the variants would win? Shouldn't the vaccine program be far enough along to mitigate the worst case scenarios?
I'll start, and then I don't know, maybe Dr. Brown may want to add. But first, I do want to inform you that as of last night and further detailed this morning, we've been informed by the Public Health Ontario Lab. We now have 8 additional cases in Ontario of the UK variant, the B117. So that means we now have 14. It's very likely we have more that we're not aware of. In those new 8, 5 of them are connected to a recent traveler from the UK. The other 3 at this point, we have been unable to get any evidence of travel, although the health unit is continuing to interview the people again, because I think it's important for people to understand how important it is to be open about a recent travel, even though they think maybe that might get them into some trouble. Of course, it would not. So, I mean, the vaccination program is going as quickly as it can, given the supply issues, given prioritizing populations. So we are prioritizing, as you know, the most vulnerable populations, the long-term care residents and healthcare workers who work with vulnerable people, Indigenous populations, and people who are patients of chronic home care. So those, as we get through those, hopefully that will reduce the rate of illness and mortality or death in those populations. It will not give us herd immunity. So in order to get what we call herd immunity, we probably need 60 to 70% of the general population vaccinated. That won't happen for many months. And so the variant is already here. We know it's, the data shows, as Dr. Brown indicated, it's probably at least 56% more transmissible. And at this point, as I said, 3 of our cases, we don't have a travel history. If that's confirmed, we have evidence then of community transmission. And that is a very serious concern that the vaccine will not be able to address quickly enough. I don't know if Dr. Brown, I think I've covered it.
Follow up?
The November modeling had the curve flattening at just under 1,500 cases. The hotspots, so-called hotspots, have been in lockdown since the beginning of December. What do you think happened, especially considering some people will say this means the lockdown didn't go far enough, but others will say the broad-based lockdown doesn't work?
I will start, and then I'm sure others will want to add. I think people are tired. It's been a long time. We're all tired. We're all fed up. We want this thing to go away. And as you could see from the data Dr. Brown showed, the mobility did not change. People were out and about in the summer, and despite going into a shutdown in the gray zones, people were still moving about. They were going to adjacent regions to go shopping. They were out and about. And I think, and we know that 1/3 of people, according to the survey, are not following public health measures. So I think what it shows is that the shutdown was not enough. We need more stringent measures. The data is showing we're in a very dangerous situation now. The number of cases is going up, the number of hospitalizations, ICU beds. We are in a serious situation, so we need more serious measures put in place.
Next question.
From Matthew Bingley at Global News.
Hi, good afternoon. Good morning, rather. My question is for Dr. Brown. Just about the percent growth that you were going through. You talked about the 5 to 7% range. Where, because it will take about 2 to 4 weeks before we see these latest restrictions to actually have any effect, where do you predict in that period that we will actually see the growth rate go?
So right now with growth consistently between 3 and 5%, if we don't see a big impact from the new variant, I think you'll just see it following right along between those two numbers. So not seeing any break. The point you're making is a very important one, a very sort of logical one. It takes a while for restrictions to affect what the case rate looks like because people need to stop moving around, the contacts need to decline. That reduces the transmission, but all the people who are infected and now incubating will actually show up as case numbers.
Follow up?
Yeah, and just to follow up on again on the growth rate, but then with the UK variant factored in, I'm just trying to see if you can drill down into that a little bit more about where we likely are with it actually factored in. Do you not know yet? Because I know we have about 14 cases, but Dr. Yaffe did mention that it is increasing and there likely are other cases out there. So do you know sort of where that growth rate is affected with that variant at the moment?
Sure. So we can't tell the exact component of the current growth that is due to the new variant and the current growth that is due to the existing variant. What we are seeing, though, is a couple, 3 things that I think are important to sort of call out. The first is a number of areas of the province with very dramatic growth in cases, which is similar to what we saw in the United Kingdom, even during their kind of lighter version of a lockdown, which starts to suggest that we might be seeing this new variant in some of these communities spreading. It's hard to tell because we don't know about the prevalence of the new variant yet. The second thing is if the variant was imported into the province as early as October, you will see that curve now start slowly to edge up closer and closer to 6 and 7%. And you'll see that almost kind of scary, sort of almost near vertical looking curve by the end of February. And it's just a matter of time as it corrects up so that by the middle of the middle or end of January, as you're asking about, you'll see a much steeper curve of, say, perhaps 7% or higher.
Next question.
From Ashley Legasic at Newstalk 1010.
Hi, thank you so much for taking my question. Dr. Yaffe, I'd like to start with you. You mentioned more serious measures needing to be enacted. What exactly would you suggest?
Well, you've seen the measures that were put in place in the other jurisdictions. The public health measures table met and discussed various options and pros and cons and the evidence. And those have gone forward through the chief medical officer to cabinet, and they will be announced this afternoon at 1:00.
Follow up?
Thank you. And we know how much older and immunocompromised people are being impacted in the hospitalization and death numbers each day. But if we continue on this track, I'm just wondering if you could reiterate how the ramifications to our healthcare system would impact an average healthy younger person.
I think Mr. Anderson might answer that. Thank you.
Thank you. Thank you for the question. I think maybe the way that I would approach that is to be very cautious about the discussion on how it might impact a younger, healthy person. We are seeing more morbidity when it comes to folks who, when you're a bit younger, you feel a little more immortal, and we're not. And we are seeing trends where people who are younger getting COVID, and although the mortality rate may not be as high, we certainly can see continued morbidity for those people. So there's really no one who should consider themselves immune until you've gotten your vaccine around the impacts that COVID can have.
Next question.
From Mike Crawley at CBC News.
Yes, hi. So the government's putting a lot of emphasis on sort of personal responsibility, people not following the guidelines as being a driving factor from that survey data that you have. What evidence is there that Ontarians are any less likely to be following public health guidelines than other places? Or could you try to explain to what extent is the lack of following the guidelines actually contributing to this steep rise of infections that we've seen?
I'll start. I don't know, Dr. Brown may want to add. I'm not sure how we compare to other jurisdictions, but we know that this infection is spread between people. And if you're not wearing a mask and you're getting within 2 meters of somebody, or you're going out when you're not feeling right, all these things, that's how this infection spreads. And, some people may have a very mild infection and they may think, oh, this isn't, I'm okay. I can go out. I can go to work. They may have a circumstance where they may not get paid if they're off sick. And that is a very, important barrier that needs to be addressed so that people will do the right thing. They may be worried about being evicted from their home if they can't pay the rent. There may be issues in their workplace. People may be taking breaks and having coffee together. Obviously, you can't wear a mask. So it's not like we're saying it's, people are doing this on purpose. I think what we're saying is people need to be supported to do the right thing. And there also needs to be good enforcement of the measures that are put in place so that people understand, some people don't think this is important. I do get a lot of emails from the public. Some of them are saying, you're making this up. This is a conspiracy. There isn't really anything happening. So, it's hard to believe that anybody actually believes that, but they are. And it's important for people to know this is real. The numbers that Dr. Brown showed, those graphs, those are people. They're not just numbers. Those are people. Those are your parents, your grandparents, your siblings, your children. And we all need to take this very seriously. I'm not sure I've answered your question, but bottom line is people need to. It's in all of our powers to change our behavior and do what we can to prevent the transmission of this infection.
Follow up.
So also to you, Dr. Yaffe, then you mentioned how serious a concern the UK variant is. My colleagues are reporting this morning about the discovery, really by accident, of some cases of B117 that were detected, by a bit of a fluke. What efforts are you going to put forward to increase surveillance of B117 to try to get an accurate sense of how widely it's spreading?
That's actually a very important question. And it's not just about that variant. Viruses do mutate. The UK variant, well, B117, people from the UK don't like being called the UK variant. But anyways, there's also a South African variant that's been found now in Alberta, and there may be other variants. So doing active surveillance and looking at the genomic sequence of the virus is really important. And actually, I was just on the phone this morning with Dr. Allen, who's the chief microbiologist at the Public Health Ontario Laboratory. They are now testing 500 to 600 samples a week. Other labs are testing as well. And, luckily so far have only found a very small number, but they need to start to gather the data together and look, and they are working as well across the country with the National Microbiology Lab and other labs so that we can identify variants as soon as possible and understand what their implications are.
Next question.
From Randall Denley at National Post. Please go ahead.
Hi, I know you're projecting significant additional long-term care deaths by mid-February. I wonder, are you taking into account the plan to vaccinate everybody in the LTC hotspots?
Thanks for the question. Yes, we are. It's one of the reasons why we're presenting a very short-term projection there. Even though with the plans to vaccinate as much as possible within the long-term care homes, you're still going to see case growth. Remember, in these hotspots, we're really only dealing with, I think, about a third of the long-term care homes across the province. And so you have to contrast vaccination in the hotspots, outbreaks now spreading across the province. And really, by February 14th, we do believe the case growth will be significant enough to continue to increase the rate of mortality. The basic point is that we're already, though, at 1,100 deaths. It's going to take a while to bend that curve down. And really, when you think about these sorts of curves, they go up and then they come back down. They don't disappear all of a sudden. So you're actually going to be probably looking at that growth and death accelerating even after we get more and more penetration with the vaccine.
Follow-up.
I'm a bit surprised at the lack of evidence about where these infections are taking place, especially in regard to essential workplaces. Do you not have that evidence?
Dr. Yaffe, maybe I'll turn out the outbreak question to you.
Public health units do follow up as much as they can, given the current huge numbers of cases in some health units, to determine, was this person at work while they were infectious? Were they at work when they might have acquired the infection? And there are certainly significant numbers of cases that are associated with workplaces. And then not only that, they spread it to their family and their household and others. So we know that workplaces can be a very important a source of infection, as can other settings where people congregate.
Next question.
From John McGrath, TVO. Please go ahead.
I'm wondering what the projections for deaths are going forward. We've already passed 5,000. Do we expect to see 10,000 people die in Ontario?
Thanks. We haven't presented overall death projections today, so I want to be careful about kind of putting an overall number on it. What I think is important to look at is that slide of the daily deaths that we showed that shows a continuing increase to really about almost 100 deaths a day under the current projections. If you start to think about that, that means that we're going to well exceed any sort of total out of the first wave. And there is a chance, particularly as the epidemic curve comes back down, to double or even exceed that 5,000 number.
Follow-up.
You've both spoken today and previously about the need for strong social supports, including things like income supports, eviction protection. if the plan the government chooses to move forward with does not include greater social supports and relies exclusively on business closures and restrictions on personal movement, can that plan still work in the absence of social supports?
I'll turn over to Dr. Yaffe to comment in a second, but I don't believe that it will. Dr. Yaffe.
Yes, I agree with Dr. Brown. I think enforcement is obviously important, strict measures and enforcement thereof and clear communication, but also needs to be with support. And I do know the government has funded, I believe, 15 what we call high-risk neighborhoods. And there is work happening around supporting people in those neighborhoods around those kinds of issues. So it's an important component for sure.
Last question.
From Natasha MacDonald at Radio-Canada. Please go ahead.
Hello, my question is for Dr. Brown. Would you say this new modeling isn't dramatically different from the one presented before the holidays? Like, as worrying as these projections are, is it fair to say you're not surprised that evidence was already pointing to the need for stricter measures than the ones in place now?
They're not substantially different. As we sort of move along these projections, you see continually sort of increasing curves, and it's consistent with the experience that we've seen in other countries.
Follow up, and this is the last question.
Quebec has vaccinated about half its residents in long-term care. Here in Ontario, there's evidence that hospital workers that aren't patient-facing have been vaccinated. Do you think it would have been helpful if the province had concentrated its efforts only on long-term care residents and staff?
Dr. Yaffe, can I turn over to you?
The province identified 4 priority groups for the first phase, and long-term care residents are obviously a very important part of that, as well as healthcare workers who work with patients, Indigenous communities, and patients who are getting chronic home care. I think, as you know, one of the limiting factors at the beginning was that we were dealing with Pfizer vaccine, which needs to be stored at minus 80 degrees centigrade, very special circumstances. And only very recently have we determined a safe way to move the vaccine. So, and it couldn't be put in multiple locations. So we started with the vaccine in hospital settings, which is not the usual way we deliver immunization programs. And it was targeted to long-term care workers and hospital workers, particularly who are seeing COVID patients either in the emergency room or the ICU or COVID units. Now we have determined how to safely move the vaccine. We have the Moderna vaccine. And so we are working very, very hard to get the vaccine into the arms of long-term care residents and those staff and essential caregivers who haven't yet received it. And the target is to get all of the long-term care facilities in Toronto, Peel, York, and Windsor done by January 21st, and the remainder hopefully by the end of this month.
Thanks, everyone.